Hello, everyone, and welcome to our presentation on the availability of healthcare and allocation of healthcare resources. Today's objectives are the introduction, define the terms healthcare availability and resource allocation, state the four basic principles of medical ethics, examine cases 1 and 2, list the medical ethics concepts for each case, suggest the path that should have been taken, and the conclusion. Before we get started, we will look at some background information starting with the introduction. Healthcare availability and resource allocation are central ethical challenges in modern medicine. Limited resources, growing populations, and rising costs necessitate difficult decisions about who receives what care. What is healthcare availability and resource allocation? Healthcare availability, the accessibility of medical services, and resources to individuals and communities. This can include the availability of hospitals, clinics, healthcare providers, and essential medications. Various factors, including geographical location, socioeconomic status, and insurance coverage, may influence accessibility. Resource allocation, the process of deciding how to distribute limited healthcare resources among various individuals, groups, or health initiatives. Given that healthcare resources such as medical personnel, equipment, and funds are often scarce, ethical considerations come into play in determining who receives treatment, which services are prioritized, and how to ensure fairness and justice in healthcare delivery. Four basic principles of medical ethics: autonomy, respect for the individual's decision making regarding their health care, include informed consent and the right to refuse treatment, beneficence, obligation to act in the best interest of the patient, providing care that promotes well being and alleviates suffering, justice, equitable distribution of healthcare resources, ensuring everyone has access to necessary care regardless of socioeconomic status, race, gender, etc. Non-maleficence, duty to avoid causing harm, weighing potential risks and benefits of treatment. AB, a 20-year-old Romanian citizen, arrived in New York in June 1985 in the hope of obtaining a kidney transplant. According to Reverend XYZ on the Romanian Orthodox Church of St. Dumitru in Manhattan, before her arrival here, all available treatment methods were tried unsuccessfully in her country. The director of the National Kidney Foundation of New York, New Jersey says Miss AB's chances of finding a kidney donor are bleak, since there is a bad shortage of donors in the United States and US citizens would usually come first. In addition, Miss AB has reportedly exhausted her funds and could not afford hospital costs even if a donor was found. In 1984, more than 8,500 Americans were waiting for kidney transplants. Only half were expected to receive one that year. Should the decision to offer Miss AB a transplant be made strictly on the grounds of her medical needs, or should her country of origin or financial situation influence the decision? Should such decisions be made by individual hospitals or at the state or national level? Given the shortage of usable kidneys, what place should compassion, medical need, and justice play in allocating organs? Medical ethics concepts, justice. In this case, the concept raises questions about allocating scarce organs like kidneys. With limited resources and a long waiting list for transplants, the fairness of prioritizing US citizens over non citizens, such as AB, comes into play. The ethical principle of justice calls for an equitable distribution that considers various factors without discrimination based on nationality or socioeconomic status. Compassion. In AB's case, her determination to seek a transplant, despite her financial struggles and being from another country, invites compassion to be considered in weighing her eligibility for a transplant. Medical need. AB's dire need for a kidney transplant due to her health issues must be considered. The medical need can often be a guiding factor in making decisions about organ allocation, leading to questions about whether her condition should afford her a place on the waiting list, regardless of her citizenship or financial status. Beneficence. In the context of AB's case, this principle emphasizes the duty of medical practitioners and hospital systems to provide care that will improve the patient's health and quality of life. Offering a transplant to a patient in desperate need aligns with the duty of healthcare professionals to maximize the benefits of their treatments. Autonomy. Although AB's circumstances may complicate her ability to exercise autonomy due to financial constraints, respecting her wishes and pursuing treatment should be factored into ethical decision making. It highlights the importance of involving patients in discussions regarding their care. Scarcity and allocation. The challenges posed by the limited supply of kidney donors force ethical frameworks to consider how to prioritize patients fairly, weighing factors such as the urgency of need, the likelihood of success, and social considerations. Dignity. In AB's case, ensuring her dignity means recognizing her humanity and worth as an individual deserving of care, thereby challenging potential biases against her based on nationality or economic status. What path should have been taken? In the case of Miss AB, the decision to offer her a kidney transplant should primarily be based on medical needs rather than her country of origin or financial situation. Given the dire shortage of donors, it's crucial to prioritize patients based on urgency and health outcomes. However, while individual hospitals may assess cases, a coordinated approach at the state or national level could ensure fairness and transparency in organ allocation. Compassion should play a role, but it must be balanced with justice to ensure that resources are allocated equitably, prioritizing those in the most significant medical need. This holistic approach can help address ethical considerations and organ scarcity's practical realities. Case 2. Mr. B is a 55-year-old suffering from medical issues, including COVID-19. Mr. B is being treated in the ICU and is intubated. He had refused to get vaccine for COVID-19, believing that he was healthy enough to handle the flu. This wasn't the case as Mr. B became severely ill and thus had to be intubated. The medical team is not optimistic about getting him off the ventilator anytime soon or ever. The hospital is overutilized with every bed in the ICU and every vent in use. After 7 days of Mr. B being on the ventilator, Mr. C is also hospitalized. He is vaccinated but is experiencing a serious breakthrough case. He will likely need ventilator support, but the expectation is that it won't be for very long. If the medical team appeals to hospital policy, Mr. C would have to wait until a ventilator is available or wait until another person declines their ongoing aggressive ventilator support. If Mr. C does not receive ventilator support, he will likely decline or pass away. Mr. C had hinted to medical staff that he did not want to be a vegetable forever. The medical team is considering asking Mr. B or his family about their willingness to sacrifice his ventilator for Mr. C. The team is asking the medical ethics team for support and guidance. Medical ethics concepts. Autonomy. In Mr. B's case, his refusal to get vaccinated showcases his exercise of autonomy, believing he can manage a COVID-19 infection based on his perceived health. However, autonomy can also create ethical dilemmas when a patient's decision leads to detrimental health outcomes. Beneficence. The medical team aims to provide beneficial interventions for Mr. B and Mr. C. In this context, the medical team must consider balancing the benefits they can provide each patient, especially when resources are limited. Non-maleficence. In this situation, prolonging Mr. B's life on the ventilator, despite bleak prospects, raises ethical questions about the potential harm of continued aggressive treatment versus the quality of life considerations for both Mr. B and Mr. C. Justice. The situation highlights the concept of distributive justice, where the medical team must allocate limited resources, ventilators, equitably among patients. Mr. C, who may respond better to ventilation thanks to being vaccinated, raises questions about prioritization based on potential outcomes. Futility. The medical team's awareness that Mr. B may not be weaned off the ventilator presents an ethical dilemma regarding whether continuing ventilatory support constitutes futile care, especially given Mr. B's poor prognosis. Informed consent. With Mr. C's condition and preferences, the medical team may consider whether Mr. B's family can be involved in discussions about the use of the ventilator, emphasizing the importance of consent even in ethically challenging situations. What path should have been taken? The likely path should involve first assessing Mr. B's wishes regarding his ongoing treatment, considering his hint about not wanting to be a vegetable. Given that Mr. C is expected to recover more quickly due to being vaccinated, the medical team should prioritize reallocating the ventilator to him, provided Mr. B or his family agree to this decision. This approach balances ethical considerations by maximizing the chances of recovery for Mr. C, while also ensuring that Mr. B receives appropriate end of life care, respecting his dignity and previously expressed preferences. Engaging the ethics committee will help ensure this decision aligns with medical ethics and hospital policies. Conclusion. This presentation has discussed the ethical, professional, and legal issues relating to the patient cases. These issues are linked and should be taken into consideration in the provision of the availability of healthcare and allocation of healthcare resources. In these cases, respecting the patient's right to autonomy, justice, and medical needs are of importance, given that the patient is competent and capable of making informed decisions regarding their care. Other ethical principles, including beneficence, non-maleficence, informed consent, futility, compassion, dignity, scarcity, and resource allocations, also play a key role in the physician's ethical decision making. Thank you for watching my video, and I await your questions in the tutorial.